Hey everyone, I'm at the PRN Physical Therapy office where we're going to talk about frozen shoulder today. This is a pretty serious and common condition in people with diabetes. If you ask me to scratch the middle of my back, I might have to scream in pain. We're going to meet Reece Jensen, who's an awesome physical therapist. You're going to learn a lot today. So the purpose of this thing is to lubricate my shoulder, to get it really, I guess, I also took 2 Tylenol before I came here. Us diabetics, we got to be careful about taking non-steroidal anti-inflammatories. So I do this for 10 minutes, and then after 5 minutes, I'll switch the direction, and it gets the shoulder kind of loosened up and get ready for the actual therapy. This is another warm-up exercise. It's a simple pulley. You can get one at home for like 12 bucks. And you're supposed to really stretch it out. So remember, it's my left shoulder, my right shoulder, no problem, but oh my God. No pain, no gain with frozen shoulder. That's the lesson I learned, because these exercises on your own at home that you get off the internet, they're just not that effective. This is all getting ready for the torture session. No, I don't want to say that in front of Reece, but it's really true. You got to get someone that knows how to manipulate your shoulder to break up the adhesions, and Reece is going to talk about that. Hello Nation. Today we're going to talk about frozen shoulder, something that I have myself for the second time. The first one was in my right shoulder, the second's in the left shoulder, and it can be very debilitating. And today I have with me my good friend now and physical therapist, Reece Jensen. Reece, why don't you introduce yourself?
I'm a physical therapist. I've been a physical therapist 31 years. I've been with PRN Physical Therapy here in Encinitas for 28 of those years. I'm an orthopedic certified specialist for 16 years, so I work specifically in orthopedics, working on spines and shoulders and knees. And, frozen shoulder is something we see a lot.
Yeah, I know. And I'll tell my story a little bit in between, but let's just talk about what is a frozen shoulder.
A frozen shoulder it's actually called adhesive capsulitis, and it's an overreaction by the body to some insult to the shoulder. It can be a minor thing, causes an inflammatory response that for some reason in some people causes a shrinkage of the capsule. And it starts off as just a little bit of limited motion, and then it becomes painful, and then pretty soon you can't do normal activities. And it's
show your,
this is a shoulder model, of course. It's a right shoulder. We call them Seymour. If we take off the skin, we can see more.
No thanks.
But normally the shoulder has a capsule, which would be like my shirt. So when I lift my arm up, all those pleats undo so that I can lift it up. If I were to staple everything to my shoulder, I wouldn't be able to lift. And so the capsule underneath the muscles with adhesive capsulitis freezes. And all these little pleats freeze and adhese and produce what's called a capsular pattern of impingement and restriction. So we can't externally rotate, we can't abduct, and we can't flex, and we certainly can't get behind the back or up to reach the seatbelt and things like that.
Not being able to do those things is one thing, but the extreme pain with those motions too. So,
well, it is an inflammatory condition. So there's an inflammation which causes pain, and every time you try and stretch those adhesions, it is very painful.
And so who gets this?
Well, every year about 3% of the population, 200,000 or so people. It's more prevalent in females, almost twice as much in females than males. Between 40 and 60 is the highest incidence. Diabetics are twice as likely to get it as sugar normal people. And it doesn't seem to discriminate between type 1 and type 2. Also people with cardiovascular disease, obesity, hypo and hyperthyroidism, and alcoholism and Parkinson's are all at higher risk than the average person.
I love that, sugar normal people. I've never heard that before, but when I saw that on the script, I thought that was funny. And I was surprised to learn that people with type 2 diabetes get it as much as people with type 1. We talk about the syndrome of limited joint mobility, adhesive capsulitis, stiff hand syndrome, but I'll tell you what, when it happened to me many years ago and about a year ago with my left shoulder,
I didn't have any trauma. It just started hurting, or at least a trauma I didn't notice. And is there any reason why people with diabetes get it more frequently?
They really don't know. I mean, obviously, an inflammatory condition, maybe there's the blood sugar is a part of that, chemistry-wise. But no, they really don't know.
Yeah, and I think it's important to say what happened to me. You know, my shoulder started hurting about a year ago, and I really didn't think much of it. And I said, "Why does my shoulder hurt?" You know, because it comes on mild in the beginning, and then I realized it was frozen shoulder, and I saw a very good orthopedic surgeon, and twice, separated by about 3 months, she injected my shoulder with steroids. You know, raised my blood sugar. I was able to handle that. It got better just for 2 or 3 weeks. I downloaded stretching exercises from the internet, and every single time I went right back to baseline. And then I got introduced to you, and maybe you'll take it from there.
So what physical therapists can do for frozen shoulder is the primary thing that we do is hands-on care, and it's mobilizing the joint. So I can't mobilize my own joint because I don't have 3 hands. I need to stabilize with one hand and move the joint in different directions and try and break or mobilize those adhesions to produce better movement. So we use modalities like heat and ice and ultrasound, electrical stim. All that's to help prepare so we get better joint motion. In your case, you had it for a long time, so your adhesions were really strong and painful. So we were working together, and I'm hurting you, and you're not able to relax, and it was actually more risky to do what we were doing at that point because I'm having to apply more force. So that's why I recommended you get the shot. And the shot, the cortisone shot, brought down the inflammation. It numbed it up, so you came in the same day. And at that point, then I was able to, as you remember quite vividly, mobilize those adhesions and get you probably 60% more motion than you had.
Yeah,
and then it got better from there.
Yeah, I should say that the third time I went in, the orthopedic surgeon, who was excellent, injected both steroids and numbing medication. I think I was here within 2 hours.
Yep.
And then during the therapy, and we're going to go to that next, not to recreate that scene, but both of us heard and felt a rip and a pop, and I went home feeling so much better right after that. And then, like you said, you know, it's just continued work and stretching.
Right. It's important to note that in order to get to that place, we have to have a good rapport. I have to know what's going on with your shoulder and know that there's not other things like osteoporosis, rotator cuff problems, because I could do more damage with that kind of mobilization if I just go in indiscriminately and do it. So we developed that. You got the shot. We progressed and we got a good result, and then you've gotten better since then because once the big adhesion lets go, the other ones are easier to mobilize.
Don't wait like I did, and it was right in the beginning of COVID. So I didn't even think that you guys were open.
Right.
And so when I finally realized that, I kicked myself for not coming in sooner because it just would have made it that much better. So, all right, so we go check out the exam table?
Absolutely.
Okay.
So in physical therapy, we get the patient warmed up either externally with having them put some heat on the shoulder, or internally having them do an arm bike or some pulleys. And then we get down to work. And the goal of the manual treatment is to mobilize the shoulder and again move that humerus relative to the glenoid and work on the accessory motions that are lost when the capsule freezes. So we've got inferior glides, anterior glides, posterior glides, and all kinds of painful stuff, right, Steve?
Right. Right.
And once we've gotten some motion, and then we work on some passive range of motion and try and utilize that motion now for functional ranges. And it's not comfortable. We have to really get into the range where the stretching of the tissue is uncomfortable to get better functional motion. Then we give them a break. Take a breath.
I could say, being a patient, no pain, no gain with this condition, and I'm temporarily in pain during the therapy, but when I leave, I feel so much better.
And you move better. You have better motion when you're done.
I was at the point where it actually hurt laying in bed if I moved my arm like subconsciously. So that's all gone now, you know.
Well, some people say I'm mean, but I'm actually just intensely therapeutic. So my goal is to get the kind of motion that you need for reaching up and reaching back and getting your arm behind your back and pulling out your wallet and all that good stuff. But that's what we do in therapy. We work on joint mobilization, soft tissue mobilization, and range of motion. Then what do we do after that? We exercise, right?
Yeah.
So pulling towards your stomach.
Yeah, that's important, yeah.
Good. Then we use those muscles through that range.
He has to make sure he didn't tear any of my nerves.
Haven't done that yet today. Push out for me. Good. And then after we finish work in the room, we usually go out to the gym and add in some proprioceptive activities to work on your sense of where your arm is in space, some plyometric activities to use that new range and strength that we have.
Reece, what about medications? What about anti-inflammatories, Tylenol, and now that Voltaren anti-inflammatory cream is over the counter, what can you say about that?
A lot of times, like when patients are in pain, if they want to take Tylenol or an anti-inflammatory or a prescribed pain medication to make this part easier and they can relax more, that helps. That helps. The anti-inflammatories may help after the treatment too to reduce more irritation and swelling. The topical cream may help. It all depends on what your preference is. If you can't take the orals because you're diabetic or because you have stomach issues, then the topical may be a good choice.
All right, we're going to wrap up here, and because we're now 6 feet apart, we are going to take off our masks so you can maybe hear us a little bit better. So I would say, Reece, since we're closing, what are some last-minute words of advice for people that may start to develop shoulder pain? And frozen shoulders typically in one side. That's one clue, right?
It usually happens in one side. Unfortunately, if you have it on one side, you're also twice as likely to have it on the other side at some point. But it won't usually come back to the same side. So if you are in the high-risk categories, if you are over 40, if you're female, if you're diabetic, and you injure your shoulder and it starts to tighten up and you can't get your hand behind your back, or you can't reach up for the seatbelt, or you can't reach across to put your clothing on or take your clothing off, then you might be developing frozen shoulders. So you should immediately try and see your doctor. And that could be your primary care, it could be an orthopedist. You can come to physical therapy directly if you use direct access, not if you're Medicare though. That doesn't work. So in some cases you can come directly to me. Most people come through the physician, but as quickly as you can, get that diagnosis so we can start, like I said, getting you through that freezing period better and having a quicker outcome.
If you're a doctor, you can write your own prescription as a referral, which I did. And I'll tell you what, I mean, my impression of the physical therapy field, that you folks, you and a lot of your colleagues can make that diagnosis very quickly and efficiently. But so it's a team.
Absolutely.
Your primary care doctor, orthopedic surgeon, and of course, physical therapist. So Reece, thanks so much.
My pleasure.
Thank you for helping me, sincerely. And I hope any of you folks out there suffering can get some help.